Yeah, good evening, sir. So welcome you all to this 33rd issue of our Association of Environment and Occupational Health DigiConnect webinar. Today, our guest speaker is Dr. Uh, Rajeev B. Ahuja, and COVID Epic updates will be delivered by our Senior Vice President, Dr. Rajeev Kumar Jain. Uh, Sir, Dr. Ahuja, sir, we welcome you all to this weekly Environmental and Occupational Health DigiConnect webinar for industrial physicians, public health experts, and occupational health physicians. Uh, Now, may I request our President, Dr. Gajen Kumar, to give the welcome address, sir. Dr. Gajen, sir.
Yes. Good evening, everyone. I welcome all the participants and both our guest speaker today in our 33rd series of this webinar. And incidentally, let me tell all my friends that uh, uh, our guest speaker, Dr. Ahuja, he was 1 year senior to me in medical college in Maulana Azad Medical College way back in 1974. He is 73 batch, I am 74 batch. And in fact, he was one of my neighbor in Moti Bagh. And not only that, he even ragged me during my college days. So I remember everything very clearly. So welcome you, sir. I'm really delighted and it is a very happy moment that we are able to interact after such a long time. And with these few words, I now hand over to Dr. Sandeep to proceed ahead.
Thank you, sir. Sir, Dr. Ahuja, sir, for your kind information, this COVID-19 pandemic, it is a great challenge for all of us, and especially for we industrial physicians. We are all working in industries, and this has proved to be a crisis time for us. And being our because of our sustained efforts and during these COVID times, we have been able to protect both the lives and the livelihoods of our workforce. And keeping this it in view, academic platform, this was conceptualized for industrial physicians, public health experts, and occupational physicians to share best organizational practices and learn from each other. So we are from Indian Association of Occupational Health, and we are all we are a 3,000 or 3,000 members. This association across India, and from Delhi, AUSD is the Delhi branch of IAOH, and Dr. Gajen Kumar is our president, and many of our seniors, they have joined from across India, and They would like to learn from you, especially before Diwali, because the fire and the crackers, although they are not allowed at many places, but still burn will be a great challenge for every one of us. And before we listen to you, sir, our Vice President, Dr. Rajeev Kumar Jain, sir, he will give the COVID updates, epidemiological updates. What is the COVID situation in India and across the globe? Dr. Rajeev Kumar Jain, sir, you can share your screen and share your presentation, sir.
Good evening, everybody, and especially Dr. Ahuja, who happens to be my senior in Maulana Azad Medical College. And we have a lot of memories of his MBBS days as well. Uh, Today's epidemiological update or COVID-19 epid updates will focus on three areas. What are those three areas? One, besides global trends, we shall focus our light on Delhi and the areas around it, because that is becoming a uh, hotbed of COVID-19 in India. Second, we will examine an important event which has happened uh, in Northern Europe, where human animal interaction can derail the entire process of vaccine development. And third, we shall examine COVID fatality, whether it is a global trend or in India. So let's go ahead and see what are the current trends in terms of epidemiology for COVID-19. So this presentation will start with, as we usually do, with the WHO COVID-19 dashboard, which is the current dashboard situation. Now let us see the first column, where cases cumulative total have reached 4 crore 85,000, 4 crore 85 lakh 34,000. And United States is well on its way to reach a stupendous figure of 9.38 million today. And India is not far behind with 8.4 million cases. And other countries are far behind. So these two countries are in race for the first and second spot in the world. Now we look at the 7 days position newly reported. In last 7 days, 35,71,000 cases were reported, out of which 6,24,000 was contributed by USA and 3,16,000 by France, a new entrant between India and USA. So France is in the race now again, second time. India reported 3,22,000, Italy reported 2,08,000. But let us see what happened in the last 24 hours. Last 24 hours, 5,81,000 cases were reported, out of which 1 lakh cases were reported by United States of America. And number two, France reported 58,000 cases, India reported 47,000, Italy reported 34,000, Poland reported 27,000, and United Kingdom reported 24,000. Besides that, Germany also reported 21,000 cases. So Europe continues to be in the severe grip of COVID-19, and USA has not loosened its grip on COVID-19 in spite of the elections being over. Now let us examine the deaths. Total deaths cumulatively, 12,31,000 deaths have been reported in the world, out of which 2,32,000 have been reported by USA and 1,24,000 by India. And other countries in Europe, like France has reported 38,000, Italy reported 41,000. United Kingdom has reported 48,000. So together, European countries have reported the second highest number of deaths cumulatively. In the last 7 days, 51,900 deaths have been reported, of which 6,000 have been reported by USA and 3,895 have reported by India, and France reported 2,999, and Italy 2,000, and United Kingdom 2,100 deaths in the last 7 days. In the last 24 hours, 8,899 deaths were reported, out of which 1,132 deaths, more than 1,000 by United States, and 670 by India. France reported 363, Italy 428, Poland 367, and United Kingdom 378. So we can say with certainty, the pandemic is continuing. The second wave in Europe and third wave in USA. And in India is still in the first wave at the moment. Next slide, please. This is the COVID death rate per million per people in the top 30 countries besides India, China, Japan, and South Korea. If you look at the top, it is Belgium, Peru, Spain, Brazil, Bolivia, and Chile, which have the highest COVID death rate per million. Belgium actually has reclaimed its unfortunate position, highest COVID death rate in the world, and death rate is rising across several European countries, as you will see in this chart. United Kingdom is 11th, Italy is 12th, and if you look at Sweden, it's 15th, France is 16th. And if you look down below, India is 66th, Japan is 112, and South Korea is 120. This is the position of 138 countries, and at the bottom is China. So this is the reality. So let us be aware and prevent deaths. Next, please. This is the COVID-19 snapshot for India. Last 24 hours, 84.6 lakh cases, 1,25,605 deaths, 116.5 million tests, and 5.1 lakh active cases. 5.1. So this is very good. 49,851 new cases in the last 24 hours, 576 deaths yesterday, 11.1 lakh tests yesterday, 7 days average test positivity rate at 4.2%, which is very good. Cases growth is at 0.56%, but a red flag. Delhi reported the highest number of cases yesterday among all states. For the first time, Delhi has reported highest number of cases among all states in India, as you will see in the next slide. Next slide, please. Next slide, please. Yes. This is the snapshot in detail about states in the country. If you look at the 4 columns, starting from left, confirmed cases, second deaths, third test per million, and fourth is on the right is 7-day average daily growth in percentage. So confirmed cases, as you know, 49,851, but at the top, look at the top of the left, the blue one or the purple one. Delhi, Kerala 7,000, Maharashtra 68770, West Bengal 3942, Karnataka 2960, Andhra Pradesh 2410, Tamil Nadu 2370, Haryana again has come up 2267. We will discuss about it later as well. So it is the South India, almost all the states. Maharashtra is showing improvement now, but we will talk about Maharashtra also. 576 deaths continues to contribute. Delhi 60, West Karnataka 35, Tamil Nadu 27. Now we look at tests per million, though India averages 822. But if you look at the bottom, Rajasthan, Madhya Pradesh, Sikkim, Meghalaya, and West Bengal. West Bengal is testing only 460, half of Indian average, and it is having very high infection. If you look further above West Bengal on the green column is Maharashtra, only 560 tests per million. Very poor testing rates. Punjab is only testing 646, Uttar Pradesh 656, Tripura 699. But good part is Delhi is testing the highest 3182 per million, 4 times of Indian average. Pondicherry, J&K, Kerala, Karnataka, Manipur. Very good testing rates. So their data is reliable, infection rate is reliable. Now we look at where the growth of active cases is occurring. 7-day average growth, Indian average is 0.6, but Kerala 1.6, Delhi 1.5, and Mizoram 1.5, and Himachal 1.5, double or even 2.5 times of Indian average growth rate is in these 4-5 states. Haryana still come back at 1.1. West Bengal continues to be in the top 1.0, Ladakh 1.0, Chhattisgarh 1.0, Meghalaya 1.9, Rajasthan 0.9, and Sikkim 0.8. So these are the states which have higher growth rate than Indian average of 0.6%. Next slide, please. Next slide. Next slide, please. Yes, this is Indian position, the trend right from July till yesterday, daily cases and moving average 7-day. Previous slide, please. Previous slide.
Dr. Rajeev, sir.
There is some audio problem, I feel.
So, Dr. Rajeev, should we continue? We can. Dr. Rajeev, sir, you're not audible.
What is that? You are seeing daily cases moving average 7-day. So what you're seeing, though it was going down, but suddenly it has stopped and now it has plateaued. So now stable at 45,000. We have to ensure the downward slide continues. Unfortunately, it has plateaued. Next slide, please. Daily deaths, there's a surge. If you look at the right bottom, earlier it was 500 and it was going down and down, but now it has again gone up to 600 now. So again, a red signal. And now we have Diwali and then the pollution. Next slide, please. Next slide. Yes. This is a snapshot, one slide, 4 graph, daily cases, daily active cases, daily deaths, and daily tests. If you look at daily cases, what I was saying earlier, the plateau, instead of reaching to the bottom, midway downslide, it has again gone plateaued and then it may go up. Daily active cases, if you look, it was going down below 0, but now again started going up. If you look at the right yellow figure, now the bottom left red figure, if you see, daily deaths again has started. If you look at right side of the figure, daily tests, they have again shown inconsistency. They have plateaued. They have not been increasing. Next slide, please. This is important slide where first time we are examining national capital region, because that is not visible because Delhi is surrounded by Haryana on three sides, and Uttar Pradesh on one side. And then there are districts which have very wide infection. So in one slide, Delhi, Gurugram, Faridabad, Gautam Budh Nagar, popularly known as Noida, Rohtak, Bhiwani, Jhajjar, Bagpat, all these towns are showing rising new daily numbers. Just look at the graph of these towns. If you look deeper, you will realize the situation is difficult to contain unless there is perfect coordination between Delhi, Haryana, Uttar Pradesh, and Rajasthan together. Unless this is done, things will not actually get under control. And additionally, if you see, many have also decreased the testing recently compared to their earlier peaks, which is again an area of huge concern. Though in this slide, I've also shown Bhiwani, I've also shown Palwal, I've shown Hapur, I've shown Shamli, I've shown Jeend. So this is what one should be concerned about if really, and this is the hotspot for COVID-19 today in the country. Next slide, please. Can you identify this animal, this huge animal? Anybody who could identify this cute animal? And this is important for COVID-19 epidemiology. Very, very important in the days to come.
Pangolin.
Anybody?
Pangolin.
This is mink. This is mink. It is used as a domestic animal in Europe as well as America. Next slide, please. What has happened is Denmark has announced that several people have been infected with a mink-related strain of the COVID-19 virus. Can you imagine? There is a strain which is mink-related. What does it mean? The COVID-19 virus, which is presently available all across in the world in crores of individuals, seems to have gone back to another animal, that is mink, and it has changed. So if you recollect what happened in China, it was an animal, then it came to human being, now it has gone back to animal, and then it has come back to human beings. So it's a grave area of concern in epidemiology if we look at surveillance technology for animal and human beings. WHO, that is the World Health Organization, is working with the Danish authorities on research and control efforts. More than 15 million minks have been culled. 15 million minks have been culled in Denmark, and 12 million have been culled in Netherlands. They have been killed and disposed under safe conditions. 15 and 12 million minks have been culled in the last 10-12 days. It is normal, if you recollect the virology, it is normal for viruses to mutate or change over time. But each time a virus goes from humans to animals and back to humans, it can change more. That's why these reports are concerning. Major variations to the virus might impact on vaccines, therapeutics, and treatments. Since the start of the pandemic, World Health Organization has worked with researchers, evolutionary virologists, sequencing teams, and synthetic biologists to track genetic changes in the COVID-19 virus. Can you imagine? These are the super specialties: researchers, evolutionary virologists, sequencing teams, and synthetic biology. These are the super science specialty that you require to control viral diseases of pandemic nature. Next slide, please. Scientists have not yet noted changes to the mink-related strain of the COVID-19 virus identified in Denmark that affect transmissibility, disease severity, or reinfection in people. But further evidence is needed. This is the World Health Organization official statement. To prevent further changes to the virus emerging among minks, and the spread of the mink-related viruses, the Danish authorities have announced that culling of all farmed mink in Denmark will commence immediately, and currently this is going on. 15 million is the minimum number. It will be more, and you will hear more about it in the days to come. Next slide, please. Today is the National Cancer Awareness Day also. So better awareness about cancer helps in prevention, early diagnosis, completion of treatment, improved outcomes and survival, and better coping. What to be aware about? Risk factors including close family history, role of different diagnostic methods, recognition of early symptoms, where to seek medical advice, and the course of illness. And never forget, cancer is a curable disease, so fight cancer with correct information. Next slide, please. Next week, this same day, Saturday, is a World Diabetes Day. The blue circle is the official symbol, and the theme this year is nurses make the difference. Nurses make the difference. Education and funding are vital to support healthcare professionals in the fight against diabetes, and people with living with diabetes need support to understand their condition and how to live with it. Visit website worlddiabetesday.org, worlddiabetesday.org, and come to know more. 6 million more nurses are needed. 1 in 10 people, they require care with diabetes. They are living with diabetes. Next slide, please. So, in summary, we can say eternal vigilance is the only thing required for controlling, preventing, and ensuring that viral disorders remain under leash. Otherwise, we will be having a race against time, and more likely we will get defeated. Thank you so much. If any questions, kindly post in the chat box or Q&A.
Thank
Thank you
you,
so
Dr. Rajeev Jain, sir, for giving the overall view of the COVID-19 pandemic and making we industrial physicians aware of the different situations which will be we will be encountering, and especially this information about the mink-related new virus. So COVID-19 pandemic is still not under control, and we are second, third, and many other waves which will be there if the people are not careful about themselves. And we as industrial physicians, we have a great responsibility. So today, Dr. Uh, Rajeev B. Ahuja is our guest speaker, sir. And Dr. Rajeev B. Ahuja is senior consultant in burns, plastic, and aesthetic surgery, Sir Gangaram Hospital, New Delhi. It will be my proud privilege, sir, to introduce you to our audience, who are all from different industries, and they will be glad to listen your views about how to manage the different burn injuries in their industries specifically, and update themselves, because we are all from different industries, and especially like I am from Indian Oil Corporation, and we are all working in this highly inflammable circumstances, where all the products and the crude and everything is highly volatile. And there are many of our friends who are working in different petroleum industries like ONGC, NTPC, then Reliance Industries. So the topic for today's will be the burns management and overview. And for your information to everyone, Dr. Ahuja has graduated from Maulana Azad Medical College in 1977, and then completed his MS in surgery and MCH in plastic surgery from PGI Chandigarh. He was appointed as consultant in Maulana Azad Medical College in 1984, from where he took VRS in 2017, and having served the department as head of the department for 22 years and bringing it to international repute. Currently, he is senior consultant at Sir Gangaram Hospital, New Delhi. Dr. Ahuja has been a top related academician, and he has almost 1,200 citations of his published research, and he was honored with the first Outstanding Teacher of the Year awarded by the Association of Plastic Surgeons of India. And Dr. Ahuja is an expert with several international and national bodies like WHO, Bloomberg Philanthropies, Center for Disease Control USA, and he has been a postdoctoral examiner and a member of the special selection committees of several universities. Recently, he has been nominated to the governing body of PGI Chandigarh by the government, and he is also on the editorial board of several international journals. He has also been conferred honorary membership by several international professional societies and has delivered many prestigious orations. And Notably, he delivered the Skims oration at annual day of the Sher Kashmir Institute of Medical Sciences in 2015 and Gill's oration of the Association of Plastic Surgeons in 2007. So, Dr. Ahuja sir, it is a great opportunity to learn from you about the burns and overall view and how to go about in our industries with this burn management, because burn injury, it continues to cause morbidity and mortality across India, and especially before Diwali we all should be aware of this particular burn details, and the adequate resuscitation of this patient coupled with meticulous wound care can have a huge impact on the outcome. And especially, like I told you, sir, we are in all volatile industries where the products are very volatile, and the surrounding communities, they can always cause some mishappenings will be there, and it can lead to some minor fires or major fires, or it can even lead to blast in different industries. So we have to be prepared to manage all these sort of cases, and especially uh, during this COVID, when the things are very they are restricted, and we all need to be very careful during this period. So, Dr. Ahuja sir, the floor is yours, sir. You can share your screen and start the presentation. Dr. Ahuja sir.
Thank you very much, Dr. Sharma, for such a elaborate introduction. I had not expected that you'll speak so much about me in the introduction. And I'm very pleased that you and Dr. Gajendra Kumar, your organization, they decided to have my lecture scheduled just before Diwali. It's a great honor to be speaking to your association. And I would like to say that Dr. Gajendra very fondly remembers me and the ragging which he had, although I remember him, but I don't remember the ragging part in it. And of course, Dr. Rajeev Jain is, I know him from college days, and he's a very prominent person, and he gives bulletins from Health Ministry almost on a daily basis, and several of them. So I'm very happy that we are speaking on this topic today. And like you yourself mentioned, Dr. Sharma, that this is the most appropriate time because as burn surgeons, we have always expected a surge in burn patients during the Diwali time. And although the government has banned sale of firecrackers, but even if you ban the sale of firecrackers, still you will hear people indulging in them. Unfortunately, burn management is not taught as a curriculum in either in MBBS or in MS General Surgery. It is very peripherally touched somewhere at all, if at all it is. And the fact is that majority of burn injuries in the country are managed by general surgeons, even though only plastic surgeons are trained in India to manage it. So when general surgeons are the ones who are primarily or in they manage burns in large numbers because plastic surgeons are not available everywhere, or mostly you can say almost 50-60% of the plastic surgeons are not even interested in treating burns because of it is a very complicated management and there is a lot of medical legal aspects attached to it. And generally the burns are suffered by the poor in the society. So it becomes imperative that we teach the first responders for burn management, and it is also imperative that it gets included as a curriculum in MBBS and in MS general surgery. Well, with this kind of an introduction, let's move further, and let's talk about the etiology. We all know that burns are caused by fire. So whether it be flame or a hot surface, this we are all familiar with. And if you come in contact with hot liquids, the burns that you sustain are called scalds. Scalds can lead to superficial burns. It can also lead to deep burns. Then you can, of course, in your industry, you know that you can have burns from acids, alkalis, electrical burns, radiation injury, and even frostbites can cause chilblains or burns. So this is very important for the people who are working in the industry and who are the first responders. That for, so let's talk about thermal burns first. So you have to stop the burning process. If there is a fire, you have to stop the burning process. Maybe you put water if it is water is available. If it is not available, you stop, drop, and roll, as is shown in the slide here, and that will smother the flames. And the water that you put on the burn uh, clothes or anything, it need not be sterile. You can just put tap water, and it need not be a cold water. It can be just normal tap water. The first responders, if it is possible, they should remove all the clothing after the fire has been smothered. They should remove the jewelry as far as possible. ABCDE of assessment is more important for electrical burns, so we'll come that onto the next slide. And consider the burn patients as a multiple trauma patients until it is determined otherwise. This also is more applicable to the electrical burns because thermal burns generally don't have additional trauma like head injury or abdominal injury or something else. And then having done all this, you cover the patient with a clean sheet. It need not be sterile. For electrical burns, the first responders, you have to first look, and you don't have to touch the patient or you will uh, get the current yourself. So you find the source of electricity, switch it off, and if you are not able to switch it off, you move the source away from the patient with a non-conducting agent. And here it is very important to follow the ABCDE principles, that you check for airway maintenance, see if cervical spine is damaged or not, breathing, ventilation, check the circulation, and then look for any disability or neurological assessment which you can make on the spot, and then control the environment whichever way you can. And then again, having done all this, you cover the patient with a clean sheet and shift the patient to the near burn center. For chemical burns, the first aid involves that you wash the wounds with plain water immediately, and you have to irrigate for at least 15 to 20 minutes with copious amounts of water so that the acid or alkali which is causing the burns, it gets diluted and washed away, and the absorption of the substance is minimized. Same you do for the eye. And then you remove the clothing which has been contaminated by the chemical. You are not to use any neutralizing agent. If you know that the burns has been caused by an acid, don't use a weak alkali to neutralize it, because this is going to lead to an exothermic reaction and it will cause further burns. Water is sufficient. And if you don't have water, if you have diphoterine, which is a neutralizing chelating agent in your industry, many industries which employ uh, chemicals in their work, the medical officers, they store diphoterine, and this helps. You can apply diphoterine to the eyes, to burns, whether they are acid or alkali. It's a chelating agent, and it is it takes acid and alkali chemical, brings it out into onto the surface, whatever has been absorbed, and it limits the damage. So if there is an advanced life support team which is available at the site, it may not always be possible, but the advanced life support team may be available at the primary center where the patient is taken from the industry or from the site of burns. So whatever is the advanced, wherever the advanced life support team is positioned, the responsibility of the team is, after having made that assessment of ABCDE, you insert a wide bore IV cannula and start fluid resuscitation. The fluid resuscitation is on uh, the lines which are for burn management, the Parkland's formula, which we'll discuss subsequently. So only two things are to be done. You start an IV fluid and you put in a Foley's catheter if it is possible to monitor the urine output, and the patient is covered with a clean sheath. That is all what the first responders are supposed to do in cases of burn injury. Let's discuss the pathophysiology of burns. Burns will cause coagulative necrosis. Obviously, the proteins, they coagulate when there is high temperature. And according to Jackson's zone of trauma, the centralized zone is the zone of coagulation where there's the maximal damage, which is surrounded by a zone of stasis. And then there is a zone of hyperemia. The importance of these zones is that, of course, the zone of coagulation is dead, but the zone of stasis gets converted to zone of coagulation, increasing the percentage of burns if there is not adequate resuscitation with fluids, or if the fluid resuscitation is delayed. So you can increase the damage if the fluid resuscitation is delayed. And the depth of burns, which happens to cause this, the zone of coagulation, is dependent on the temperature to which the person is exposed. Like at 44 degree or 42 degrees centigrade, you can expose the person to any number of time, any length of time, and there will be no burns. But as you increase the percentage, so something like 75 degrees centigrade or 80 degrees centigrade, it may take just a second or less than a second to cause the zone of coagulation. And then as soon as the burn takes place, there is a release of inflammatory mediators like bradykinin, cytokinin, interferons. And once they are into the stream, they increase the capillary permeability. With the increase in capillary permeability, the pore size increases and all the intravascular proteins, they leak out into the interstitium, into the extravascular space, leading to edema of the burnt skin. If burns are more than 30% of the total body surface area, these inflammatory mediators will cause capillary leaks even in the unburnt skin, leading to large fluid losses in the third space. The fluid may, in large burns, may be lost into the abdominal peritoneal cavity and into the ileum and other places, and you can have a large amount of fluid loss. And this is where the role of fluid resuscitation, which is very vital when the patients are burnt more than 30%, it is very imperative that the resuscitation starts immediately. So all these biochemical changes which happen, they happen as a result of the fluid shift which is taking place and the cell damage which has happened. And when the fluid comes into the extracellular space, it gets absorbed by the cells, and the sodium gets absorbed into the cells, thereby causing hypernatremia. And as a replacement from the cells, the potassium leaks out into the extravascular space and then gets absorbed into the intravascular space. This should cause hyperkalemia, but the hyperkalemia is not seen if the patient is adequately resuscitated. Because there is dehydration, if the resuscitation is not initiated quickly, there is hemoconcentration also, which leads to elevated blood osmolarity, hematocrit, and it causes the blood to become more viscous. And at the same time, the patient also has metabolic acidosis because of the washing away of the bicarbonate, and lactic acid production. Basically, the metabolic phases can be categorized into three parts, three stages. The first few hours, there is a pain response because of which there is a release of catecholamines leading to tachycardia and tachypnea. And then there is the more important phase, the phase two, which lasts for up to 24 hours, which is initiated because of the inflammatory mediators, and there is shift from the intravascular to the extravascular space, which we discussed. The third stage starts after the 24 hours or 42 or 48 hours. And this is the very important phase also because this is the catabolic phase in which all the proteins which have been lost and all the damage, coagulative necrosis which has been caused, it increases the basal metabolic rate almost 2 times the normal if the bones are more than 30-40%, which makes that there is a large need for the body to have extra nutrients, both calorie and proteins. If you look at this slide here, you can see that if there is a fracture, then only the BMR goes up by 10 to 20%. If there is general sepsis, then another 30 or 50% increase in BMR. But if you have burns more than 30%, it goes up to almost the 2 times. And this increase in the BMR is quite linearly increasing with the rise in the percentage of the burns. And when it reaches about 30%, then it plateaus out, and then there is no further increase. The heart also gets affected quite a bit because there is a release of tumor necrosis factor with the burns. If their burns are large, more than 30%, which decreases the myocardial contractility, leading to hypotension and organ end perfusion, hypoperfusion. And hypoperfusion is not just because of these cardiac changes, but hypoperfusion is also because if the fluid resuscitation has not been complete. And the first response of the vascular system is that there is splanchnic hypoperfusion leading to ileus. So immediately if there is a massive burns for 50-60% burns and you try to feed the patient orally, the patient is going to vomit and may even aspirate. Respiratory changes also take place because of inflammatory mediators, and they also take place because of inhalation injury. Inflammatory mediators will cause bronchoconstriction, and in severe burns, it can lead to acute respiratory distress syndrome. There is a problem in gas exchange because the alveoli are full of fluid. Inhalation injury we'll discuss subsequently because it's a very difficult situation to manage if the patient has inhalation injury, and we'll deal with it later. Now, because so much of protein loss has taken place, some of the protein has coagulated, some of the protein is leaking out of the burn wound as exudate. And if there is not enough replenishment, it will lead to downregulation of the immune response. And this downregulation will be both for cell-mediated as well as humoral pathways. And this is the reason why burn surgeons, if there's a major burns they are treating, they're always giving concentrated albumin 10%, 20%, or they're giving plasma infusions so that the proteins can get replenished because the need for high protein replenishment is very high. So these are the various degrees of burns which we classify. If the burns are just limited to the epidermal surface, it is a first degree burns. We'll discuss each and every burn subsequently. If the burns, they reach up to the papillary dermis, this is the papillary dermis, then this is a superficial second degree. If the burns reach deeper in the dermis, in the reticular dermis, this is called the deep second degree burns. And if they go below the dermis, it is a third degree burn. And then you have burns in the subcutaneous tissue, in the muscle, and going up to the bone, which generally happens in cases of electrical burns and not in cases of thermal and chemical burns. First degree burns are generally of not much significance. It is, you can say, if you suffer sunburns, it is called a first degree burn, as shown in this picture here. You can also get it if you have, if you are sunbathing in an ultraviolet chamber, you can sustain sunburn, you can sustain first degree burns. And the tissue is very red, erythematous, and extremely painful, but it heals absolutely fine without any scarring. And when we are talking about percentage of burns, then first degree burns is not counted in the percentage of burns because there is no fluid loss taking place in first degree burns. So that is why I say a first degree burn is of no consequence in calculation or in treatment of burns. It just needs little bit of emollients and dressings, and this will automatically heal in less than a week. So if you have the next level of burns that it is involving the papillary dermis, this is what you see, that there is a pinkish hue to the burns. This may be a blister which has burst, and these blisters and these wounds are extremely painful because the nerve endings to the superficial dermis have got exposed, and these are extremely painful. If you press on this burn wound, it blanches. This again will automatically heal in 2 weeks' time. It just needs a little bit of protection, some dressings with some antibiotic cream, antimicrobial cream, and it will heal automatically without any ado. If the burn goes into the reticular dermis, this is where the major trouble starts. The burns appear like this. There are many nerve endings which have burned. There are many blood vessels which have got burned. The skin appendages, majority, 80%, 90% of them would have got burned. So it is difficult for the area to heal on its own by resurfacing and reepithelialization from these skin appendages, because the number of appendages as you go down, it decreases. So these burns, if they are allowed to heal on their own, they take about 3 to 4 or 5 weeks to heal on their own, because the superficial dead tissue has to come off and then the epithelialization has to start. And the problem with these is that the longer it takes for them to heal on its own, it leads to bad scarring and hypertrophic scarring because the reticular dermis is involved. So we'll discuss subsequently how these burns are dealt with. But what is very confusing is for burn management is that burns are not crystal clear the way I have shown here in pictures here, because some area of burns will it will all be, there is a one area which is third degree, one area second degree, deep dermal, one is superficial, and they a large area of burns, it is very difficult to say that all of it is either of one type. So you have to deal with these kind of burns also, and devise appropriate management. Third degree burns are, like I said, when the full thickness of the dermis is involved, there is no dermis left. These burns, they just cannot heal on their own. All the vessels have coagulated. The area is totally insensate because all the nerve endings have uh, been burnt, and there is complete destruction of the tissues, and they don't heal without surgery. The skin looks black like this. It also looks like parchment like. If you touch it, is dry parchment like. And these wounds, they dead tissue, the eschar has to separate. Either it separates on its own or you remove it surgically for it to, and then graft it after preparing the wound. How do you estimate the burns? So these are rules of 9, which is very easy to follow in adults. The head and neck area is 9%. The front of the abdomen and chest is 9 each. So it is 18. Each limb, upper limb is 9%. Each lower limb is 18%, 9 front, 9 back, and 1% for the genitalia. And you can make an approximate guess of the percentage of burns in adults like this. In children, it's a different rule because when the baby is born, the head is disproportionately big compared to the lower legs. So we have a rule of 5, in which the head, front, and trunk and back, they're all 20%, and each limb is upper limb, lower limb, they are 10%. And as the child grows up, you deduct another 5% from the head, lower limb, posterior trunk, and add it to the upper limb and anterior trunk. So these are the rules that you can follow and make an estimate. But in children, it is very difficult to make a correct estimate. So majority of people, they rely on Lund and Browder charts. These charts are established charts. These printed charts are, you can see in any burn unit, and so the residents can refer to them. Depending on the age of the child, you can, and the extent of burns, you have these charts and you can refer, and this is little more precise. Sometimes you can also need to assess if there are patchy areas of burns and you find it difficult. One palm surface of the patient is equal to 1% burns. So if you have a patchy area, maybe small 5-6% burns, then if it is fitting 5 palms of the patient or 5.5 palms, then you can say, okay, the burn is 5% or 5.5%. And that is also quite a good estimate to make in smaller areas. Now, once the patient reaches the burn unit, how do you assess whether this patient needs admission or not? If it is a thermal burn, then adults more than 15% and children more than 10% because they need fluid resuscitation. This fluid resuscitation and they need monitoring. So these patients, they need to be admitted. If it is a full thickness burns more than 1%, then third degree burns more than 1%, this will need to be admitted because this wound will never heal on its own. It will have to be excised and grafted. If there are circumferential burns of the thorax and extremities, so this thorax and extremities circumferential burn, it may be just 20-30% burns on the upper chest, but this will require admission because it causes difficulty in breathing, or it may cause a vascular compromise. If there is inhalation injury and there may be no burns, it's just inhalation injury, this patient needs to be admitted. If you remember the Upahar tragedy, none of the patients ever sustained any burns, and they all died because of asphyxia due to inhalation injury. If there are burns of special areas like if face burns, hand burns, genitalia burns, then without uh, calculating the percentage, these patients need attention and admission. Otherwise, they will lose their function, which is very vital. All chemical injuries and electrical injuries, they need to be admitted. And all patients who have a coexisting trauma, because they may have a fall, or they may lose their consciousness, they may have psychiatric problems, or other coexisting medical conditions, all these patients, they need admission. Now, coming to inhalation injury as a separate entity. So inhalation injury can be of 3 types. You can get inhalation injury above the glottis. The injury above the glottis is because of the warmth air which you have inhaled. It's a thermal injury which has caused above the glottis, and you have not inhaled the fumes which has gone below the glottis. So there is swelling and erythema in the mouth, the oropharynx, the nasal cavity. There is a change in voice, stridor, and this presents very early, within few hours only. If the steam is inhaled below the glottis, it goes below the glottis, or there is a smoke which is there, then the lower bronchi and bronchioles and alveoli, they get affected. Patient gets acute respiratory distress syndrome. There is cough and carbonaceous sputum and hypoxia. The other thing can be that there is a carbon monoxide poisoning. The chemical of the smoke, the carbon monoxide poisoning, or a hydrogen sulfide from burning plastic or wood, they get absorbed into the blood, and they cause, besides chemical pneumonitis, they cause poisoning, and they alter the mental status and respiratory distress. And fortunately, carbon monoxide poisoning is not so common, but yes, it happens. So you have to have a very high index of suspicion for inhalation injury. And if there is any patient, you take a history we must always ask whether the burns was sustained in a confined environment. Many Indian households, they used to have kitchen, which was a confined environment, and this used to be the place. If there is a fire in the kitchen, then patient is likely to have inhalation injury. So you must take this history. If you see that the facial hair or the nasal hair are singed, if patient has got facial burns, and if there are burns of more than 50% body surface area, all these four things, it doesn't matter. It doesn't mean that the patient has sustained inhalation injury, but there is the index of suspicion goes higher. And then when you see on direct visualization that there is erythema or swelling of the oropharynx, or if there is a change in voice, there is hoarseness, there is wheezing, labored respiration, patient is coughing out carbonaceous sputum, there is a continuous cough, or the patient has mental altered status, this is confirmatory of an inhalation injury. Now, you don't have to wait for the changes on the right side to happen before you take action, because it may become too late. So you have to preemptively intubate before the stridor develops. So if you suspect that the patient has all these four things on the left hand column, then it is much better to do a bronchoscopy, diagnostic bronchoscopy. And then if it says that patient is fine, there is no edema, there is no erythema, you may continue with normal treatment. But if you find that there is any evidence of edema which is developing and there is erythema, you must intubate the patient, even if the patient has not shown any signs of change in voice or wheezing or carbonaceous sputum, because then it may get very late. How do you manage inhalation injury? It is actually pretty difficult, because it's not just a question of giving oxygen or monitoring the acid-base gases and keeping the patient in propped up position or giving chest physiotherapy or antibiotics. But the thing is how the body is responding to all this treatment, because the inhalation injury, there is no way to gauge that what is the extent of inhalation injury, except when the AVG gets altered seriously, or there is the pH level is going down. So you have to be very careful and keep your fingers crossed when the patient has sustained major inhalation injury, because it really complicates the thermal burns if it is there. And that is the reason why there were large number of deaths in the Upar tragedy. You may have to give positive pressure ventilation in extreme cases to keep the alveoli patent. So this is the fluid resuscitation we were coming to, whether the fluid resuscitation is started by the first responders or it is given at the burn center. It is very vital that the patient starts receiving fluid immediately after burns as soon as possible, because you know that within first few hours only there is so much of leakage of intravascular fluid to the extravascular fluid. There is hemoconcentration, viscosity of blood. It can damage, it can cause acute tubular necrosis, and it can cause several problems. So you have to start the fluid resuscitation as quickly as possible in any primary center that you are seeing the patient. The published Parkland's formula is that you give 4 ml per kilogram body weight of the patient per percent of the burns in 24 hours. And this is fluid is Ringer's lactate. Half of this calculated volume is given in the first 8 hours of burns, and this is calculated not from the time you are seeing the patient, but from the time of burns, because that is the time from where the leaking starts. And the next half of this calculated volume is given over next 16 hours. So this is this formula or any other formula. There are several formula for resuscitation. This is just the popular one, which is used by many people. So I'm just mentioning this. These are all rough estimates, and you have to monitor that your resuscitation is adequate by maintaining a urine output of 0.5 to 1 ml per kilogram per hour. And this is where it is essential to put Foley's catheter and monitor urine output every hour to see that it is above half to 1 ml per kilogram per hour, so that you can say that the resuscitation is adequate and the patient will not go into acute renal necrosis. At our institute, almost 2.5 decades back, I had modified the Parkland's formula to 3 ml per kilogram per percent TBSA in adults. And that was because of my clinical observation that when we are giving 4 ml to most of the patients, the third space loss is so much that it causes compartment syndromes in the abdomen and otherwise in extremities. So it can cause further complication. And since all these formula are rough calculations only and basic monitoring has to be done by urine output measurement, so you start the resuscitation with 3 ml per kilogram per percent and then obtain half to 1 ml. If there is a need for more fluid to be given, you can add fluid to 3 ml and then you don't risk the patient will go into abdominal compartment syndrome. Now, for the last, surprisingly, for the last 10 years, and I did this because it was my clinical observation, and for last 10 years, there are papers which have been published with scientific evidence that yes, you should give at 3 ml per kilogram per percent TBSA adult. This doesn't mean that the 4 ml formula is wrong. What it means that some people, some patients, they need 3 ml, some need 4 ml, some need 5 ml, and some even need 6 ml to maintain an adequate urine output. Like in inhalation injury, you need a much higher rate of fluid. In electrical burns, you need a much higher rate because the electrical injury that you sustain, it may be very tip of the iceberg and the large volume of burns may be just under the surface. In inhalation injury, the lung has got a very large surface area, and if a small piece of lung is even damaged, it increases the TBSA of burns tremendously. Similarly, in children, they have large body surface area compared to the body weight, and therefore they need larger amount of fluid. But for all the other patients, 3 ml is sufficient. So this is what you need to keep in mind and not blindly follow anything. If you monitor the urine output properly, then you are all right. So like I said, urine output measurement is what is required, which is essential. You don't need to put CVP in these patients. CVP is only put supposing the patient has come after 6 to 8 hours of sustaining burns, has not received any resuscitation, and half of the fluid volume calculated has to be given in the first 8 hours. Now, how do you give? If only 2 hours are left or 1 hour is left, how do you give half of the calculated volume? It runs into 4 or 5 liters for major burns. So what you do is you put a CVP line, start 2 drips, large bore drips, and just open the tap till the CVP becomes normal, because this is the only way of obtaining adequate resuscitation in cases of delayed resuscitation. Otherwise, you won't need a CVP. Urine output is good enough. These are routine investigations which I have listed, which are carried out. One of the important ones is a wound swab culture sensitivity. You, after the third or fourth day, you do a wound swab and keep the culture reports handy so that you can decide if the patient goes into septicemia, what is the sensitivity pattern for the antibiotics that you need to start. When the burns are sustained, the burnt area is sterile because with the thermal injury or electrical injury, the surface bacteria also they get burnt. So obviously there is no need to do a wound swab culture in the first 2 or 3 days. After 4th or 5th day, they start the fecal matter and the urine. They can start contaminating the burn wounds, and you do a wound swab. Electrical injuries, you need to be a little more careful because they can lead to ECG changes, and they can be atrial fibrillation or supraventricular tachycardia. You have to watch for that. You have to watch for compartment syndromes because, like I said, the burn on the surface may be just the tip of the iceberg. There may be large muscle necrosis underneath which you have not, which is not visible immediately. And when this swells up, this compromises the blood supply to the extremity and can cause loss of limb. So you need to do early fasciotomies, which are limb saving. As soon as there is earliest sign of a compartment syndrome being developing, you do a fasciotomy. Maintain a high urine output up to 1 ml per kilogram And like I mentioned, these patients, they need more fluids. So if you see that the electrical burns, the patient is only 5%, it may not be 5%, it may be under the surface, it may be 25%. So irrespective of the percentage of the burns that you may calculate, these patients have to be catheterized. Otherwise, the patients will go into acute renal failure, and which is not just because that you have under resuscitated, it may also be because there is myoglobinuria caused by loss of pigments from the burnt vessels. Analgesia, tramadol, Fortrin, Phenergan, midazolam, any of these, or you can rotate these, they are enough to cause control of pain. A word about antibiotics. It is fashionable amongst doctors and sometimes with burn specialists also, in spite of what they might have read in the books. Prophylactic antibiotics are not given in early post-burn period because this leads to resistance. And burn patients has a very prolonged convalescence. If you have a 50-60% total body surface area burns, the patient will remain in the hospital for 2 to 3 months and will go into repeated episodes of wound infection, septicemia. And if you start prophylactic antibiotics, you will start it for 7 or 8 days, then you will change, and the patient is still not gone into septicemia, and all the bacteria will become resistant to the common antibiotics, and you will be, when the patient actually goes into septicemia, you will be not left with many choices. So it is better not to start prophylactic antibiotics in any of these patients. And sometimes, if to show somebody that you are giving antibiotics and not neglecting, you can give penicillin, ordinary benzyl penicillin, because in spite of uh, irrational use of penicillin over last almost now 80, 90 years, strep has not become resistant to penicillins. So if you have to give, you can give this, but there is no need to start something like Monosef or Amicus and things like this, because it is irrelevant in the initial post-burn period. So I did mention that nutrition is very important because there is a lot of exudation of proteins which is taking place. But initially, because of ileus, if there is a major burns, you don't feed the patient for first 24 hours. You can put in a Ryle's tube because the patient is in ileus. But it is very important that after 24 hours, once the resuscitation is complete, the patient has recovered from ileus, you must start oral resuscitation feeding. It is very important because if you don't feed the patient after 24 hours, you can start gradually, but if you don't feed, then there is translocation of the bacteria from the gut into the systemic system, because there is inactivity, mucosal activity. So the bacteria from the gut, they get absorbed, and this causes septicemia. So it is seen that you must start oral intake as soon as possible. And to prevent stress ulcers, you can give proton pump inhibitors or H2 blockers for few days. Best route for nutrition is oral route because the gut is not burned. You can put in a Ryle's tube and give the adequate amount of calories from this. You can devise burn diets which are high in protein. You can need to give 2 grams per kilogram per day. A very high calorie requirement is there, as we see on the column on the right hand side, plus all these vitamin supplements and mineral supplements you need to add because they are all diminished in quantity. The normal body requirement for food is about 25 kilocalories per kilogram, and you add 40 kilocalories per percentage of burn. So you can see each percentage of burn, it increases the calorie requirement by so much. So this is a calculation, rough calculation, which is shown here. For a 60 kilogram man with a 40% burn, you would need almost 3,000 calories. And there is a formula given here for the juniors. So you can imagine that if it is a 60 kilogram man, he will require almost 120 grams of protein. It is not easy to give 120 grams of protein. So you have to see that you make adequate replenishment. Otherwise, the patient will go lose his immunity and will easily go into septicemia. So obviously, like any first aid measurement, you will check for tetanus status. If you are a first responder and the patient has only small blisters because of superficial burns, you don't need to open them. You can just put a non-adhesive dressing with a paraffin gauze. You may or may not apply topical agents if these are small burns. And uh, you don't apply topical agents because if it is a larger burn, because when your patient goes to a burn center, it will be very difficult for the burn surgeon to assess the depth of burns. He'll have to remove the topical agent. So today we say don't apply any topical agent, and 20 years back we used to say don't apply toothpaste, don't apply Bernol, don't apply Colgate or something, which they were the remedies suggested by aunts and uncles. But today we say don't apply topical agents because it is a fashion that the first responder will apply silver sulfadiazine and then send the patient to the hospital. And then if I see the patient, I don't know what is the depth of the burns because I have to remove that silver sulfadiazine to see. And that removing of the process of removing the topical agent can itself cause injury to the burns, further injury. So these are the topical agents which are all listed here. It is not that silver sulfadiazine heals burns. It doesn't. Sulfamylon is another burn which is specific for burns, and silver sulfadiazine is specific for burn. It doesn't mean that they heal burns. And whenever you hear the word burn, you must apply silver sulfadiazine and nothing else. You can apply anything from this list, depending on the extent of burns and what is available at that moment. Silver sulfadiazine and sulfamylon, they were devised as specific for burns because the infection in burns takes place below the eschar. If you have a full thickness burns, the eschar below that in the subcutaneous tissue, the infection multiplies. The bacteria, they multiply in that zone. And if you apply a topical cream, it does not penetrate the dry eschar to reach that place, the sub eschar, to control the infection. So that superficial cream which you are applying is of no use. Therefore, silver sulfadiazine was devised because in such major burns with deep burns, you want the antimicrobial agent to penetrate the eschar and control the sub-eschar infection. This is where silver sulfadiazine is important. This is where sulfamylon is important. And soframycin, we have done a study and published it, is as good as the other two. And then the others which are listed here, they have different roles. But for you, if you are in your practice, you can use any of these. Sulfamylon is unfortunately not available in India. And then you have to dress the wound. So you have to dress the wound with a non-adherent material. Which the best material is Vaseline gauze. You may use a chlorhexidine impregnated like a Bactigra. You may use a foam dressing if there is exudate is too much. You may use a hydrogel dressing which because reduces the pain. You may use an alginate dressing. You may use modern dressings like Suprathil. You can use any of these dressing, but don't use plain gauze because the plain sterile gauze will stick to the wound, and when you remove the gauze, it will cause damage to the healing epithelium. There are newer silver containing dressing materials. And why silver containing dressing materials? Because over the centuries, silver has been used as an antimicrobial, and bacteria have not become resistant to silver. And therefore, something about 50 years back, people rediscovered silver, and first it was introduced silver sulfadiazine, and then they said, okay, we'll have silver impregnated dressings, nano silver impregnated dressings. And then the Convatec people, they came with hydrofiber dressings with silver so that there is more absorptive capacity. And then there is another, and there are several other dressing materials, but all with silver. These are expensive dressing materials, and they are non-adherent, and they are quite useful if you have large superficial or large deep double burns. They are quite useful. So for electrical burns, for thermal burns, I said if there is a circumferential extremity burns or in the hands, then you need to do an eschorotomy like this to prevent the compromise of the blood supply. If you have an electrical burn, you need to cut the fascia under the eschar so that the muscle bulges out and the vascular compromise doesn't happen. and you have to do this before the vascular compromise develops, before there is extreme pain, before there is any sign of ischemia. Otherwise, you will lose the hand. So you have to keep monitoring the patient and do it as early as possible on the first index of suspicion. Otherwise, you will lose the limb. There are two modes of treatment: excisional surgery and conservative management. So excisional surgery is the one which is done most commonly in most of the modern burn centers. But the problem is that in Indian burn centers, like in Safdarjung or Maulana Azad, there are a large number of patients which are coming in, and it is not practical to do excisional surgery in all of them, because there is a lot of requirement for blood transfusions, for operating time, for ICU care. You need a lot of skin graft, so you need too much of donor sites. If a patient is burned 60-70%, you don't have enough donor sites, you don't have available homografts. But it does decrease the morbidity, it decreases the hospital stay, and there is an early coverage of the burn wound. Conservative wound management means that you keep dressing the patients till either the superficial and deep dermal burns they heal, or the third degree burns, they eschar, it uh, comes off by its own. Because of the subdermal infection, it leads to more morbidity, there are more chances of infection, there's a longer hospital stay, and it is only suitable for Indian or low income country scenario where there are a large number of patients and there are low resources. Surgery is of two kinds. If it is a second degree deep burns, like I said, when second degree deep burns they happen, they will take maybe 4 to 6 weeks to heal on its own, and they will heal with hypertrophic scarring. So it is better to tangentially excise with the help of this knife. You excise it tangentially till a healthy bleeding surface, normal healthy surface is reached, and then you skin graft it, autograft it, or you cover it with a biological dressing till enough autograft is available. In a third degree burn, because it is total eschar, you have to take a scalpel and remove it surgically and then graft it. If enough autograft, because you have to autograft it, you cannot take except anybody else's skin, so you have to autograft. If enough autograft is not available at the moment of excision of the surgery, you can use homografts, or you can use from cadavers or live donors from parents. You can use pig skin, you can use artificial substitutes like Integra, BioBrain. Amniotic membrane is a very useful biological dressing which you can use, and there are collagen dressings which are available. This is not available in India, but this technology has been around for almost 30-40 years. It is very expensive technology. You can grow, you can take a bit of epidermis from the patient or bit of dermal cells, grow them in the laboratory. You can grow them as a composite matrix also. The matrix has both the dermal cells as well as the epidermal cells, and you can use these, and this is a substitute for the autograft. That is because the seeding of the epidermal cells are those of the patient, and it is grows on a dermal matrix. Still, this technology is not available. It is only lab-based in most of the places in India. So all the healing may take place, but you have to be very careful that the patient doesn't develop contractures. Contractures develop on flexion surfaces if they are not adequately splinted. So you have to see that the patient gets early ambulation. There is active physiotherapy during the daytime. Night, you must splint the patient, and physiotherapy is started as soon as the patient is hemodynamically stable and you can make him stand or do exercises in the bed. Patients are given pressure garments for scar management, which is very important. Otherwise, this limits the hypertrophic scars. And there are various kinds of splints as they are shown here. You can have an aeroplane splint for the elbow. You can have hand splints like this. You can have cervical collars. And you have to nurse the patients without pillows. Otherwise, it encourages neck contracture. And so you need a full department of occupational therapy within the burn unit to devise all these splints, and physiotherapy person available to carry out the exercises. Thank you very much.
Thank you, Dr. Rajeev sir, for giving such a broad overview of burn management. Being a surgeon, I too was not aware of many of the things because, as you told, that burn as such is a very wide topic, and you have covered it from etiology of the burns to resuscitation in different scenarios, different type of burns, then phases of metabolic changes, the respiratory changes, the degrees of burns, burn extent estimation, when admission is required, when to get the person admitted, then different type of inhalation injuries, then fluid resuscitation, lot of areas you have covered, sir. Nutrition, then wound management, especially the dressing materials, which sort of dressing material we should use, then biological dressings, then different surgical aspects also of this management, like assurectomy or fasciotomy when it is required, when it is not required, then excisional surgery, conservative management, and even in the rehabilitation period, the prevention of the contractures, role of physiotherapy, the pressure garments. So, as a industrial physician, this is a very broad subject which we all need to be aware of, and different aspects of wound management and different aspects of patient management and rehabilitation that has to be known to us. So although in this small time of about an hour you have covered the almost the whole burn, but still we would like you to answer certain questions from our respected panelists from across India who would like to ask some questions from you, sir, regarding
Sure.
bone.
Most welcome.
Yeah. So, Dr. Gajen, sir, if you have any question.
Yes, first of all, my compliments to Dr. Ahuja for such a wonderful talk on the subject, and he has made everything, almost everything, clear to us in such a short time. So, my compliments, sir.
Thank you very much.
Now, my question is, see, in the country, the incidence of burn is spread all across because the many a time, rather most of the time, burn injury occurs at domestic level in the house, be it a kitchen fire or otherwise. But the facilities to treat burns are not even available up to district level. District hospitals are not adequately, able to manage these burn cases. So one reason maybe due to lack of competent manpower, as the specialists are very low. How you suggest that these facilities are made available even up to the peripheral level, minimum district
So,
level?
so almost about 15 years back, I've been at the helm of affairs for National Academy of Burns India, which is the National Association for Burn Management. And some of the senior colleagues, we collected together on this thought, and we proposed to the Health Ministry to start a national prevention program for burn management. And it has been adopted as a plan. Dr. Jain will know about it, that there is a national program for prevention and management of burn injuries, which is underway. And in this, the scope of the plan is that all the medical colleges in the country and uh, I think 2 or 3 district hospitals in every state will get covered. So I don't know, since I'm not in the government now for last 3 years and I was out of touch, so I don't know how much, to what extent this program has progressed, but it had done quite well. And there's Dr. Tanu Jain who's spearheading this program in the ministry. So the government thinks about it, but the problem is that burn management is so expensive. You need so many experts. It is taught only to plastic surgeons, and 50-70% of the plastic surgeons are not interested in treating burns.
Absolutely.
And it is mainly treated, the responsibility comes to general surgeons who are having nursing homes or who are working in district hospitals, and they are not taught the management of burns. So we have CMEs like this one organized by National Academy of Burns India and other forums where burn management is taught, and this has been going on for last 20 years. So I'm happy to share that many people who are interested in burn management have now an inkling of how to manage burns. And it is only when they are not, when they think it is not in their capacity, they refer to the burn unit, because the capacity of the burn unit is also limited. If you send 60-70% total body surface area burns to a burn unit, and the burn unit gets 2-3 patients like this every day. So instead of the patient dying in the district hospital, this patient will die in the burn unit. And then the reputation of the burn unit goes down because they don't have those resources to treat so many serious burns. So it is a national health problem, and therefore, because of this, we had proposed to the government that you should have a national program on burns, just like leprosy or tuberculosis program.
Okay.
Hopefully, maybe in another 10-15 years, things will improve. India will become more wealthy. And as you become wealthy, the nation becomes wealthy, the per capita income increases, the incidence of burn injury goes down. So that
Right.
also helps.
Right. Thank you.
So, burn problem is a national problem. That is very right, sir. And especially in industries, this is also one of the major problem for, especially in our petroleum industries where we are all working. So main incident and accident, they are because of the burn, and it is difficult to manage those particular patients because first hand responders and the first aid and our refinery hospitals, they are not well equipped to manage the whole burn cases. So ultimately they have to be referred, and once they are being referred, even the sub-regional hospital or many other reputed hospitals, they don't have bed capacity or the necessary facility for admission of these particular cases. So it is better we all work together for prevention of the burn injuries, and that will be an important aspect for every one of us. Dr. Rajeev Jain, sir, would you like to?
Yes. In fact, I would say Dr. Ahuja's work has not gone waste, because October 2020, the national program for management of trauma and burn injuries has been mainstreamed as part of National Health Mission. If you can recollect, Dr. Ahuja, 47 medical colleges were given funding. Training manual has been revised, which you had
Yes.
initiated.
Yes.
That has become part of standard treatment guidelines. It's become very important in the context of acid burn victims, if you recollect. The people's participation and the legal help, government has actually fast-tracked this process of what you proposed as a national program. And this is going to, I feel, really help in actually mainstreaming burn management. As you were advocating, it is not the responsibility of the plastic surgeon. Rather, it is the waste of resources of plastic surgeons to be able to manage burn injuries. Burns, as such, require a primary healthcare approach and a multidisciplinary approach, which can only happen through the National Health Mission integration. And if we look at this NHM currently with RSBY and Prime Minister's Arogya Yojana, this has, in health and wellness centers, this has been included, the burn management protocol. So everybody on the ground is aware how to manage the rational way of managing burns. So I think this is a very crucial moment to understand that your effort has borne fruit. The government is taking up it in big way, and financial support is available. And the standard treatment guideline that has come out covers almost all the areas that you have outlined in your talk. One question, besides, I must appreciate the way you have simplified the entire presentation, very complex issue. And it has been evolving over the last 25, 30 years. I've seen right from Loknayak Hospital, how we have kept on learning how to have better outcome for burn patients. My question relates to a question which we've always been talking, but not actually finding a solution to it. Which particular patient will require antibiotics, or are antibiotics a necessity for burn patients? And when should we start it?
antibiotics are very important in burn management. It is just that you should not give them prophylactically. At the first sign of earliest sign of infection, if you there are so many signs of infection. At the earliest sign of infection, I don't want to go into the details, but if you have say fever, or if you have counts going up, or if you have something else, if you have diarrhea, that may be very late. But at the earliest sign of infection, you start the antibiotics, and in broad spectrum and in full doses. It is just that if the patient is not in any infection, and if the patient may not go into infection for 10 days, so there is no need for antibiotics in this 10 days. But if after these 5, 6 days or 10 days or 11 days, you patient shows any sign of infection, then you must start antibiotics in full doses, broad spectrum, combination, depending on the culture report which you have saved in your file. Because by fifth or sixth day, you would have got the culture reports, then use the culture sensitivity reports and use those antibiotics in full doses, and then keep monitoring. So antibiotics are essential, and I'm very pleased to know that in October the National Health Program they moved this forward, and it is very important. And if continues like this, then I'm sure in 10-15 years time we'll improve our burn management to a very large extent. And as the per capita income goes up, the incidence will also go down, and there'll be some semblance of normalcy, because at the moment, for several decades now, India has been the burn capital of the world. And when I was the president of the International Society for Burn Injury, it used to be quite embarrassing for me to say that I come from India where we have all the burns. In fact, I used to mock the other people and say, why do you people become president? Burn is our problem and we should be the presidents.
Well said.
But well, there is a question here. Let me please answer that question. It is I would like to answer that live. The question is, when are the blisters after burns? Should the blisters be allowed to heal on their own, or should you open them with with aseptic precautions? This is from Dr. Sudharma Dalvi. And thank you for this question. See, when are the blisters? So I told you that blisters form only in superficial second degree burns, because the overlying burnt tissue is thin. There is exudation taking place because there are a large number of blood vessels in the superficial burns. There is exudation taking place, so there is a blister formation. If you see a blister, you should be very happy, because a blister means that it is a superficial burns and it will heal in 2 weeks' time. So people generally, lay persons, they think, oh, blister ho gaya means mushkil kaam ho gaya. No, blister ho gaya is very good, because if it is not a blister, it is a deep burn, and it takes a longer time to heal, or it may require surgery. So now the question is, what do you do with the blisters? So if it is a small blister, you don't need to de-roof it. You can just simply dress it. You may puncture it to take out the exudate. After you have punctured it, the blister can remain in situ, and it will act as a biological dressing, and it will come off when the epithelialization has taken place under the blister. If these are large blisters, then these are large areas where there is an exudate which is collecting. So you have to de-roof these blisters and then treat them accordingly. So small blisters, you may not de-roof completely. You may just puncture and take out the exudate. Large blisters, you may need to de-roof, and the de-roofing should be done in a surgical setting by any competent surgeon. So does that answer your question?
Yeah. Thank you, Dr. Rajeev, sir, for this. Now, Dr. Tyagaraj, sir. Dr. Tyagaraj, he has joined from Bangalore, and he's also Dr. Tyagaraj. You can unmute yourself. You have to unmute yourself.
Can you hear me, sir?
Yeah. Yes.
Sir, at the outset, it is a wonderful lecture by you, starting from burns to that rehabilitation. You have done a very good, and thank you very much, sir. For it's a wonderful and very impressive seminar lecture given by you, sir. Thank
Thank
you,
you very
Sharma
much.
ji.
Thank you so much.
Dr. Tyagara sir. Dr. Pinde sir, can you put on your video and you can, yeah, Dr. Pingle is our past president and he is member of the International Commission on, he is board member there, International Commission on Occupational Health. Sir, Dr. Pingle sir.
Yeah, thank you very much. It has been an excellent lecture, as everyone has unanimously said. I spent most of my lifetime in petrochemical and industries and other industries where burns was a major issue. So for me, it was a wonderful revision, right from basics till the advanced things, and in a very short time. So thank you so much.
Thank you so
One,
much.
yeah, one small question, sir. I mean, of course, you have very rightly said burns is a problem. You can look at it from two angles. One is the social angle, where it happens domestic, and second is the industrial angle, with which we are more concerned today for this lecture session especially. I just wanted to know your views on diphoterate, because there is a lot of is it really worth the cost that it is, or is
See,
there more hype about it?
diphoterine has been made available in India only recently, last few years only. It was not available in India. And it is high cost because anything which is new and like this, it takes a lot of time in research. Now, I have personally not used diphoterine because how will I use diphoterine? I was working in Loknayak Hospital and the patients will come to me very late and I have not
Yeah.
used diphoterine. My experience with diphoterine is what I've heard in international lectures. So these are the people who promote diphoterine. There are now some papers coming from India, from Ahmedabad and other places where there are more industries. They have diphoterine which is available. So they are using and they are reporting good results with it. But I personally have no experience with diphoterine.
Okay. Okay, sir. Thank you. Thank you so much.
Dr. Sandeep, you have to unmute.
Any of our petroleum industries, they are keeping diphoterine in their first aid center, especially in Indian Oil Corporation. We are having it at our first aid centers, so where it is being used effectively wherever required. So Dr. Kamla Fartiyal, she is GM Medical from NHPC. She is also our Vice President. Dr. Fartiyal, madam. Yeah, you have to unmute yourself.
Good evening, Dr. Sab. That was a wonderful lecture. I think it will help each one of us in treating patients who come to us with burns. And we often do things which sometimes which we shouldn't. As you said, we apply silver nitrate and give these burns patient the first aid. And when we refer them, as you said, I think every time I hear this, I learn that there is a new thing which we have to be careful for while giving emergency treatment, especially for burns patient. I wanted to know one thing, Doctor. Uh, when a burns patient comes to us, especially the second degree burns, do you clean the wound with a saline or you just apply a paraffin film gauze?
No, you always clean the wound with saline.
Saline.
Always. Any wound, burn wound, you must clean with saline because you have to remove the dirt.
That's true.
There may be dirt which is collected there. So you remove with saline
Yes.
and do it gently, because if you do it in a little more crude manner, you are going to damage the surface and it can cause harm to the patient. So do it gently and do it with saline. After saline, you can clean it with the povidone iodine if you want, and then apply a suitable topical antimicrobial. It is not necessary silver sulfadiazine. Choose your antimicrobial. Choose your antimicrobial and then apply it. If it is a large wound, large burn wound, then you cannot apply something like gentamicin, you cannot apply neosporin because it will lead to toxicity. So you have to choose the topical agent. Then you may use soframycin, you may use silver sulfadazine in large wounds, but
Okay.
in smaller wounds, you can use anything you want. Even povidone iodine is sufficient. If they, you may not even need a topical agent. You may just clean it with saline, use paraffin for small superficial burns, and dress it and change the dressing every third, fourth day. And in 2 dressings, 1 week, the patient will be healed.
Another thing, Dr. Saab, sometimes once I had a patient who had immolated herself, and she had come with, I think, 80% burns. So in such cases, what do we do? Can we afford to apply some antibiotic ointment, or just cover the patient with a clean sheet after cooling it with water?
See, the chances of an 80% burns surviving in India
Yes.
is negligible. An 80% burn to survive in India is negligible.
Mm.
So if you refer this patient to a burn center, you are
Yes.
not doing any service to the burn center, you are doing disservice to the burn center. And the patient's mortality will be the same, whether it's in a big burn center or whether you are treating. So the patients, if you are in the decision-making position, you can say that you will treat the patient if you have enough facilities. If you have enough surgical facilities, you retain the patient, start a IV fluid, and you may not give systemic antibiotics because that is not going to help, and you may dress the patient. Now, this dressing is not treating the patient. This dressing is preventing the bad smell which may come from the wound. So you are changing the dressing every day, like you are giving a shower to the patient every day because you know this patient has to die. So in many countries, like still in Netherlands and a couple of other countries, they don't resuscitate. They start the drip and make it so slow, not according to the Parklands. So the patient dies from failure of resuscitation. So
Okay.
they write, do not resuscitate. Now,
Okay.
what happens is that when I was in Maulana Azad, every other day we'll get 1 or 2 patients who are more than 60, 70, 80%. But I could not do this do not resuscitate treatment. I had to tell my residents to give full treatment. And then this full treatment which I give will keep them alive for 7 days, 10 days, 2 weeks. And then they die after 2 weeks. So what are we doing? We are wasting the hospital resources, giving hope to the relatives. Ultimately, I know from inside the patient will die. So this is a very difficult decision. And since I've told you the facts, you can decide whether you want to retain the patient or refer the patient somewhere.
Okay, Doctor. Thank you very much, Doctor.
You're welcome.
So, can you throw some more light over this newer silver impregnated dressings?
See, so we have established that silver is very important antimicrobial agent in modern times also because it has been in use for centuries and it is a very important material. Now, how you are going to give silver to the wound, either as a silver sulfadazine, which has less absorption, or as a nano silver, or in hydrofiber, or in silicon foam, or in some other form. So when there is a superficial burns, or little more deeper than superficial burns, if you apply these silver dressings, you don't need to change the dressing for 3-4 days. And silver acts as an antimicrobial because it stays in the wound. If you are using silver sulfadazine, it is written in books, you have to change the dressing twice a day. But we don't change the dressing twice a day, we do it once a day. So it increases the labor. And the more dressings you do in superficial burns, you are likely to cause more damage. So these dressings, they will prevent the infection and you will not need to change the dressing for 3-4 days. If there is an exudate, these dressings will absorb the exudate and it will not leak out of the dressing material. So these dressings are very important from that point of view, and the epithelialization takes place underneath very smoothly. But the only drawback is these dressings are expensive. But then burn management is expensive in all aspects. So these dressings are little expensive.
So we can reduce the frequency of dressings with the help of this.
Yes, you can reduce the frequency of the dressings. So if you have a 15-20% burns, which is superficial, which is or little more than superficial, not very deep, you can do these dressings, and then you don't need any topical agent with this because it itself has silver in it, and you can change the dressing every third, fourth day depending on whether the dressing is soaked or not, and then you can take the decision.
There is another question in the Q&A box regarding
Yes.
potato peel and fish skin and banana leaves in dressing.
Yeah. So potato peel was introduced by a very, very senior burn surgeon of the country, one of the first or second pioneers of surgery in India. And he's no more. And banana peel was started by his protege, who was head of surgery in Sion Hospital, Madhuri
Yeah.
Gore. But unfortunately, these are not based on scientific evidence. There is no, everywhere you say you should have randomized controlled trials. Why are Ayurvedic drugs not used liberally? Why is homeopathy not used liberally? Because there are no randomized controlled trials. They may work, they may not work. How do you prove to the world? So I think it is best we leave it at this, that there is no scientific evidence that it works. But anything which is protective of the burn wound and it is superficial will heal regardless of what you apply on it. A superficial burn has to heal. My teacher used to tell, a superficial burns, you apply cow dung and it will heal. Why are applying potato peel? So this is what I can say.
Great. Thank you.
Thank you, sir. And sir, one more decision. Actually, it is a very difficult decision for us to give our opinion regarding this management of the by excisional surgery or by the conservative management, because many surgeons they propose for the excisional surgery multiple grafts and early grafting. So how we should decide as industrial physicians?
Excisional surgery is the best. If the burn surgeon is competent and he has the facilities for enough biological dressings available to him, and the patient can afford it or your company can afford it, then excisional surgery is the best. Otherwise, conservative management of wound dressings and separation of eschar and then grafting is a poor man's choice.
Okay. So, but it has to be done at a proper center where all the facilities are available, and
It has to be done at a very good center.
yeah,
At a very good center. Tom, Dick, and Harry's cannot handle this.
yeah. So it was a good presentation by you, sir, and we would like to further coordinate with you regarding taking this journey forward regarding burn management in our industries. And regarding prevention, would you like to give some tips, or before this Diwali season, what we all should do? Because in our industries also a lot of these rockets and other things they used to.
So I don't know which industry, because in Delhi there is a ban on firecrackers. So see, the thing is that we used to always propagate that first don't burn crackers. But if you have to burn crackers, then two of the most dangerous ones are the anar and the rockets. So if there is an anar, you have to not hold that anar. So there is a story that Amitabh Bachchan got burned because he was burning an anar in his hand and this happened during my residency days. And in you keep the anar at a distance and use what do you call a phuljhadi to light it. So you are at a distance from the anar. In rockets also, you don't hold the rocket and burn it. You can keep it in a bottle like we all used to do in our childhood. So these are the standard ways of doing it. If your children are playing with crackers, you have to supervise and keep 1 or 2 buckets of water always handy when they are playing with crackers, so that immediately when there is a fire, you can use that water. Otherwise, if there is a burn, you will go looking for water and you may not get a bucket. So these are some of the things that like first aid, I have already mentioned that you stop, drop and roll and put water on this, cover with a clean sheet, remove the clothes. And if you are say in a big town or something, you can easily reach any hospital within half an hour to 1 hour. So there is no need to rush. Previously people used to rush, इसको जल्दी से अस्पताल लेके जाओ, जल्दी से अस्पताल लेके जाओ. And we have come across several people who used to meet with accidents just because of this haste. So you have to be careful, and otherwise if you just keep bucket of water and you are careful with crackers, so you will not sustain burns.
Right. And one more thing will be the electrical burns, because of the lightning and other things. Lot of loose wires may be there in.
Yes.
Because
So you have to be careful. Basically, prevention is just that you have to be careful. Careful of everything.
Yeah. So prevention is the vital factor that will have an impact on decreasing the morbidity and mortality associated with the burns, and the education and training are the vital steps. And we would definitely like to take forward this journey which we have started today with you, sir. And from our side, because of the new norms, we have designed a small certificate which we will be sending you through email, sir. So that will be on behalf of our president. So
thank you very much. I may just end saying that burns is an accident. Burn is not deliberate. Burn is an accident, and all accidents are preventable.
right, sir. Right.
Absolutely.
So you take home this message: all accidents are preventable, and so are burns. Just enjoy your Diwali and be cautious how you celebrate it.
So,
Thank you very much for having me here. I really enjoyed my presence, and I enjoyed delivering the talk to such a good audience. And you,
sir,
and it was very nice connecting with Dr. Jain and Dr. Gajendra after so many years. And obviously, I keep hearing of Dr. Rajeev Jain. I know him through many other forums, and it was wonderful being here.
yeah,
Pleasure.
thank you.
And in spite of you not being well, I was noticing you have,
Yeah,
nose,
I've got allergic rhinitis, and this pollution does a damage.
yes.
So this is the reason. It's because of pollution I get allergic rhinitis.
Oh.
Despite your this allergic rhinitis, sir, you have been able to teach us. We are able to learn from you, and all this recording will be available on our YouTube channel, sir. So it will be loaded soon after this session. And I thank you very much once again, and I will thank Rahul and other people from Convatec also for introducing you to us. And we will definitely like to take this journey forward specifically with our industries. We'll call our industrial doctors from different industries, and we would like to learn from you for this prevention and management of this wound and burn injuries, because definitely accidents, yes, burn is an accident and prevention is the best cure. So thank you very much, sir. Thank you, Dr.
Thank
Raj.
you. Thank you so
Thank you.
much.
Thank you so much. Thank you.
Thank you.
Bye.
Thanks.